On April 8, 2026, the panel of expert pulmonologists gathered in a virtual roundtable to discuss how they're using CyPath Lung, a non-invasive test using flow cytometry and AI as a tool to increase their clinical confidence in managing next steps in care for individuals with small pulmonary nodules who may be at a higher risk for lung cancer.
My name is Dr. Gordon Downie. I'd like to thank bioAffinity Corporation for providing this platform for our audience and for our panelists. So I'm a first-generation interventional pulmonologist. I trained at UNC Chapel Hill. I've mostly published in photodynamic therapy, early lung cancer diagnosis, and bronchoscopy education. I joined CyPath as their chief medical officer about 12 months ago and have had a wonderful year working with them and talking about our product. We're fortunate tonight to have a wonderful expert panel who have significant experience in this arena and have added CyPath Lung to their clinical practice algorithms. We have Dr. Guda joining us from Fort Worth. He's an interventional pulmonologist and specializing in robotic bronchoscopy, airway stenting, and minimally invasive diagnostics in lung disease. We have Dr. Michael Nicholson joining us from Robert Wood Johnson practice in New Jersey. He trained at Temple and he does pulmonary and critical care. And lastly, we have Dr. Greg White joining us from Texarkana, Texas at St. Michael's Hospital. He specializes also in pulmonary and critical care. He assesses about 500 pulmonary nodules every year, so very expert panel. I'd like to ask our panelists to talk about some of their challenges that they face in this interesting arena of assessing pulmonary nodules. Dr. Guda, perhaps you can start our discussion.
Thank you, Dr. Downie, for introducing me and bringing me into to talk about this. You know, as an interventional pulmonologist and as somebody that does quite a bit of robotic bronchoscopy for diagnosis of these small nodules that we previously could not get to, it's raised a very interesting question as to what we do with the smaller, and if you're able to access smaller and smaller nodules, or we're able to go to those portions of the lung with a robot that we have never previously been able to get to. The question is, well, if you can do it for every single patient, should every single patient actually get that procedure that comes with a lot of risks associated with it? In our practice, we have a very robust practice, and we do quite a few number of pulmonary nodules, as well as advanced interventional procedures, including laser stenting, debulking, pleural biopsies. A lot of times, the type of patients that we are seeing come in quite apprehensive because they either have a history of smoking, or they know somebody that has had lung cancer, or they've had family history of lung cancer, and now they've got this abnormal spot that is there in their lung, and they are unaware as to how they want to proceed with it. So one of the methods in assuaging some of the grief that the patient may experience with that initial diagnosis, shock diagnosis of, hey, there is something here on this CT scan that's concerning, is to help risk stratify them. And that's essentially the biggest portion of why CyPath works. There are certain patient populations that do better with risk stratification, and there are certain patient populations that just want to go forward and get a biopsy and be done with it. But either way, this piece of data informs us as to with what clinical confidence I can go in when I'm performing the biopsies to help answer those questions. So in most of our patients that are coming in, our practice is predominantly an oncology-driven practice. We have a lot of oncologists that refer to us, but we have a not insignificant number of patients that come to us through the ER, through primary care, through general pulmonary, and all of those nodules that we see can have a varying degree of risk. And so we do utilize it in those patients whose, the Mayo risk calculator is insufficient in giving you the information, or you have got a nodule that does not meet lung RADS 4B, and then you are thinking, I need to do a biopsy of this. Maybe, but there's risks associated with it. The patient may not be the best patient to take for anesthesia. Well, we definitely have a role for CyPath there to help risk stratify, and then the patient gives us the patient's their own sputum gives us their information, and then we proceed with the next steps, whether it's management with biopsy or management with imaging on at a reasonable cadence. That is something that is informed because we have another tool to help us with risk stratification there.
Dr. White, you have a very busy practice in Northeast Texas. Maybe you could describe the challenges that you face in dealing with pulmonary nodule assessment.
Well, and kind of echoing what Dr. Guda was saying, and kind of more in my simplistic way I think about it is not every patient needs a procedure, and not every nodule needs a biopsy. It's just kind of an easy way to think about it. There's always risk anytime you put somebody under for a procedure. There's always this scary thing if you're going to biopsy. That being said, risk stratification is always great. It's encouraged me to go after procedures, had patients get procedures. It's encouraged me not to go after procedures that I've even used it sometimes with the patient was high risk for a procedure and the PET scan was positive and this was positive. I've had radiation oncologists go ahead and start treating based off of that risk stratification. What I'm seeing with nodules is we've had a huge influx of low-dose screening CTs through our hospital system. We're doing about 120 to 150 a month now, not counting what I'm already tracking, and I'm getting more and more nodules coming in, and you just can't spend all day bronching and finding a way where these things settle out at.
For Nicholson, you're on the East Coast in New Jersey. Can you talk a little bit about your practice challenges with pulmonary nodule assessment?
Absolutely. I think one of the biggest things is I try to keep up to date on a lot of medical literature, podcasts, webinars, and things, and I'm inundated with my mediastinal cryobiopsy, Monarch versus Ion, all of these new tools and tricks, and everything is about how do we biopsy better, but not who is the better person to biopsy. And I think that's a really important thing for us to focus on because the prevalence of lung nodules is increasing and we need to utilize the resources correctly. So my fellowship was at Temple Lung Center. The bronchoscopy suite was 2 ORs that both had ions and cone beam CTs. Every 6-7 centimeter nodule, millimeter nodule, someone wanted to take a poke at it. And now I'm in a community-based practice with an academic affiliation, several groups, high volume of nodules, smaller amount of ion time, and we have to find out who are those patients that are the best suited for it. Everything in medicine is about pre-test probability. So before you go into a biopsy, who are the patients with the highest pre-test probability to actually have a cancer? That's who you want to biopsy. And our current tools for that are not great. We have multiple calculators. In the ViewMedi talk, we showed how multiple calculators show different scores. And some say biopsy, some say don't. So what are you trusting? And so when you have a non-invasive diagnostic test like CyPath, it helps you to have a better pre-test probability before you make a decision like that. Because this burden of nodules is only going to increase. Right now, most insurances and Medicare will cover the USPSTF guidelines, which say former smoker or current smoker or those who have quit within the last 15 years. But for several years, the American Cancer Society has been encouraging people to remove that quit within the last 15 years and just anyone who smoked for more than 20 pack years. And then if you've got a chance to review the new cholesterol guidelines from cardiology, they are really encouraging the use of coronary artery calcium scoring. And I have a lot of incidental nodules in my practice found on coronary artery calcium scoring. So there's just this real need to figure out who are the right people and optimize that pretest probability.
Absolutely. So for our audience, I know a lot of the clinicians that are listening tonight have similar problems and feelings that our panelists touched on. And just to review again very quickly, there's a rapidly evolving increased burden to all clinicians based on what you just heard from Dr. Nicholson, Dr. Guda, and Dr. White. So why is this burden exploding? Increasing screening. Finally, we're hardwiring a lot of family practice doctors, internal medicine doctors, and hospital systems are hardwiring their screening for the high-risk individuals. Also, what the definition of high risk is expanding every year. We're finding out that non-smoking related lung cancers are increasing in the population. We have now probably 10 to 20 carcinogens that most of the U.S. population is exposed to. So who's at high risk? That's an expanding population. And now with AI-driven mining of EMRs, there's more and more hospital systems that are finding every time a pulmonary nodule, quote unquote, is mentioned in an EMR. And as pulmonologists and clinicians dealing with in this area, we are getting the full burden of this.
And it's a great point that Dr. Nicholson made is the 15-year benchmark is an arbitrary number. It is based on old data that doesn't really have the same kind of consensus as smoking history positive, smoking history negative. So there is an increased awareness in the community as well, where we have a larger population of patients that do get sent to us from the primary care physicians, and those patients have a variable risk factors. There are also physicians that say, hey, I've got this 3 millimeter nodule. I do not know what to do about it. I am just going to go ahead and send this to the lung clinic for management. And then the patient comes in quite worried. I have a 3 millimeter nodule. Are you going to biopsy this? Is this cancer or not? Right? So that is where the patient population variance comes. Now, with oncology, patients that have had breast cancer 5 years ago or cervical cancer 10 years ago, and they are being monitored for something or the other. They have had abdominal pain. They do a CT scan of the lung. They see a small nodule, get a dedicated CT scan, and then you get a small nodule on that. And then what do you do with a 6 millimeter nodule? How do you risk stratify somebody who has had a history of solid organ cancer and you have a 6 millimeter nodule that is there on their lung, and now you have to choose, do you biopsy, do you not biopsy, right? I would say that a lot of our patients that do come in with nodules that may not be amenable to biopsy, but you still have enough of risk factors, we do have them get us CyPath samples, sputum samples to send for CyPath for us to be able to say, hey, this is their risk factors. This is what we see on the data coming out from them now. The nodules have not changed in a year. Let's repeat it again and see how we can assess it.
Dr. Nicholson, maybe you could comment about nodules, how they come into your practice and your practice algorithm, and how you employ CyPath in your practice.
And I think Dr. Guda had touched on something important there when he said the anxious patient, right? And so we'll talk a lot tonight about data and about workflows and things, but at the end of the day, a lot of times there's a patient with a 5 millimeter nodule sitting in front of you, and you as a clinician knows that this is probably nothing, but them as a patient with ChatGPT thinks that this is the end of their life. And so having CyPath as a way to bridge that gap between when's the repeat CAT scan, if you're not going to go after this for any reason, and relieve that anxiety for patients is a huge part of it that I wanted to bring up as well. For me, I'm in a practice with 10 other pulmonologists ranging in age from me, who's at a fellowship recently, and pulmonologists who finished med school in 1984. So we're all over the place, and me and one other physician does most of our biopsies. So a lot of our referrals come from the community cardiologists who get CACs and primary care doctors who do a lot of screening. But we also have a very large patient panel who's doing LDCTs every year. And then I receive a lot of the referrals to do the biopsies. Basically, all of my colleagues who have patients who have a nodule, they will send and say, what do you want to do? Do you want to biopsy this? Do you want to do a PET? Do you want to do? And I say, well, let's start off and let's get a CyPath. It'll take us a few days to get the results. The patient just gives a sputum sample, and then we're going to know a better pretest probability of what the best next steps are. So it works in very early to my algorithm in a lot of these nodules, especially the ones that are less than 1.2 centimeters and the ones where PET is more unreliable, 7, 8, 6, things like that.
I would love to hear from Dr. Guda, maybe with a case that you've had.
So this is actually one of the first cases where it was like the first use case for CyPath for me, because I'm a skeptic at heart. I like a very healthy dose of skepticism with my morning coffee. So whenever there's any new piece of technology that comes through, I like testing it and making sure that it actually works. So this is actually a very interesting patient. She's a 66-year-old female who's known for her history of smoking quite about 5 years ago. And She developed abdominal pain, some discomfort. She has got some vasculopathy in the abdomen, so they thought there was some sort of an obstruction taking place, or essentially ischemia. They did a CT scan of the abdomen pelvis, and they noticed some ground glass changes in the base. So the next thing they did after that was, hey, we're not sure what this is, but let's get a CT angio also, because we think that, or a CTA of the aorta, just to make sure that there is no evidence of vasculopathy. And they caught ground glass nodularity in the right upper lobe, with other ground glass nodularity throughout the entire lung. Now, based on her history, it is not a very solid nodule. It is at the most, in the greatest dimension, about 13 millimeters. It's not very suspicious, but it is a little bit suspicious, where you are considering, and based on the history and the surrounding emphysema in a patient that had quit smoking just recently, that maybe there's something more to this. But how do you risk stratify it based on all the other modalities that Dr. Nicholson was touching on? Every single modality that you put in for risk stratification, it gives you a different number. It gives you the benchmark the goalpost keeps changing, right? So in those situations, we thought maybe we should do a PET scan, because the patient got sent over to us from the ED for this nodule. The patient was quite nervous about it, obviously. She had some family members and some, not immediate relatives, but friends, have lung cancer, develop lung cancer. She was worried. PET scan wouldn't be very informative because the solid component is less than 6 millimeters. So we looked at what the follow-up options were available to us, which was both like a 6-month CT scan, watchful waiting for 3 to 5 years. But the patient was given that she has family members who developed cancer, and now we are worried about something that's going on in the lung. So she's aware of what that means and what that looks like. So we decided to go forward with CyPath. This was, I think, our third or maybe fourth patient that we had set up for CyPath. The pre-screening risk was low, and the CyPath results came back 0.7. So we, at that point, were quite surprised. We proceeded with discussing risks and benefits of a biopsy. We did a robotic bronchoscopy and performed a cryobiopsy, which is where you freeze the tissue and you pull it and you get a larger chunk of tissue. And lo and behold, it was positive for adenocarcinoma. She was then sent for tumor board review. We reviewed her case, and it was early invasive adenocarcinoma. She had a PET scan done, the full gambit, and because the ground glass nodules were only isolated to the right upper lobe, they elected to go forward with doing a full right upper lobectomy on her because of all the other. And this patient, I think this was about a year and a half ago, and she has had follow-up CT scans that have been cleared thus far. She did not need any further testing, and sure enough, it was early invasive adenocarcinoma in this patient. So this was one of those first patients that made me a believer, I would say, that there is a modality out there that can be reliable in comparison to some of the other modalities that are there, where this patient profile doesn't fit under those models that other risk stratification profiles are available, right? So this profile of this patient fit just with this watchful waiting. When we are nervous about following through and just doing watching for somebody who has risk factors, and the biopsy seems too aggressive because of surrounding emphysema, risk of pneumothorax, all those things, this really is helpful. This CyPath really was helpful to push us into the direction of doing a biopsy, where I, at the time of evaluating this patient in the clinic, was not convinced one way or the other that we should be doing a biopsy. And I'm glad we did, because now she is potentially lung cancer free.
I did receive a question just now to go over some of the statistics of our clinical trial. So our clinical trial for CyPath Lung was published, peer-reviewed published, and we reported a 92% sensitivity, a 87% specificity. We provide data as a binary, either likely or unlikely. And this is based on our negative predictive value, which for nodules less than 20 millimeters is 99% positive predictive value. Dr. Guda's case, based on the specificity and positive predictive value of 61%, benefited, obviously, the patient benefited from that positive predictive value. So we have a very robust clinical trial demonstrating I think, best in industry, sensitivity area under the curve of 89%, and specificity, as well as the positive and negative predictive values. And as you know, everybody's prevalence in regional United States is slightly different. And that's why the negative and positive predictive values are so important.
As you raised a good point that I always think is important for me. Out of the statistics, the positive predictive value is actually the weakest statistic there at 60%, but the negative predictive value is really high. And so going back to my statement that not everybody needs a procedure, not everybody needs a nodule, if I can give somebody peace of mind that this is truly not likely cancer, there's no reason to put them through a procedure. That being said, it's also all comers. When they cough up their phlegm, they're identifying cancer cells. It's not saying it's a squamous cell or an adeno, a prostate, whatever other lung, breast cancer. It's all comer cancers that is coming out when they cough up. And you're saying, yes, it's going to be a cancer, or it's not with the final results with the biopsy. But the positive predictive value is about 60%. So you still ultimately have to get a biopsy if it's positive. And even then, it's not always going to be a cancer, but it kind of gives you a risk stratification on who do you need to watch closer, who do you need to kind of pursue quicker. But if it's truly negative, I feel much more comfortable let things ride. And that's what's kind of nice about it.
The next question is, what patient populations have you found that CyPath may be more likely to give false positive results in, or in what situations would you not recommend using it? That is an excellent question. We have a huge study that we've started with 2,000 patients, and I think we'll better answer that when that study is at completion. But clearly, what we see for the negative predictive value is we had an interesting case where someone had florid thrush. And that sample, it turned out to be unlikely. And then we realized in our lab that all of the patients, when there's a heavy population of yeast, we were getting negative values. And we realized that the yeast was blocking the gating in the flow cytometry. So now that is one of our exclusion criteria, active thrush. And so I think we're going to find more and more about what we need to exclude and include as we go through our bigger study. The positive predictive value of 61% is very competitive. It's comparable to the Cologuard test for colon cancer, and certainly stands up to imaging mammography for breast cancer. So even though that sounds like a weak number, it's actually very predictive. And I do think, again, the bigger study will show some of the reasons for positive predictive value being at 61%. Two questions almost identical, asking about the low percentage of screening that we see in the United States. I'd like each of the panelists to comment. Do you think CyPath as a adjuvant supplemental test will allow us to do better with screening?
I have a very interesting take on this. Patients, when you tell them you have got to go and get screened to find out if you have cancer, immediately go, well, I don't want to know. Or I don't think I have cancer. I don't feel bad. I don't want to go through with the testing because you're unsure. At the end of the day, unlike a colonoscopy where you go in there and you see a polyp, you resect the polyp, you've essentially taken out the precancerous spaces, the lesion, and you've also screened them at the same time. An imaging study like this, it's different, right? So in patients that when they are going to go get a CT scan done, shell so much of money out, most of them living very much under their means, giving them a test that says, hey, listen, you meet several risk criteria. Doing a screening for you is going to tell us something. Whether it's really bad emphysema or really bad, or you've got pulmonary nodules that need to be evaluated, maybe doing this sputum testing may help them understand the importance of it. Because you're doing more than just screening them for the nodule that they have, but you're also going to risk stratify them not at the same time, but in sequence. And sometimes patients may seem a little bit more willing to go forward and get a CT scan done if they have a known higher risk, not just by numbers, by saying you were a smoker or you had quit smoking 15 years ago or like 12 years ago, you still may be at risk for developing this. So while you want to have a nodule when you're performing this, I wonder, it's a question, I wonder if those patients that get screened with a sputum test first, you define whether or not they're having increased risk based on their sputum analysis, and then they do the CT scan. Will that increase the number of patients that we actually collect for biopsy that are going to be positive down the line just because you've had a risk stratification test done first? So it's an interesting take. It's not imaging and then you do the risk stratification, but it's like putting maybe the cart in front of the horse kind of a method. But I wonder if that is something that might help improve the screening of patients that are already at risk at all.
And Dr. Guda, I've heard similar questions along that line, so that's an excellent point. Dr. Nicholson, what are your thoughts on this?
Yeah, and I think, like even our scopes we steal from our GI colleagues. But so now I think, on the ViewMed talk, I talk about the similarities between fit testing and this. And so finding the ways to identify those patients who otherwise would not be screened and use some kind of screening for them in terms of this testing. And there's a lot of concern in my area and my practice from patients with radiation. And it's a true concern from them. They don't want to be getting CTs every year. A nodule pops up, you have to follow it again in 3 months. So I had one gentleman who said, like if I didn't have cancer before, I have it now from all the CAT scans people are ordering from me. So to have a radiation-free way to try to risk stratify somebody, I think that's the future of all early detection in all across all medical specialties, is to do it in the most effective and least invasive way possible for the patient safety, for healthcare utilization and costs, and to figure out how to increase that pretest probability, like I mentioned, to find the patients who really do need a CAT scan and really do need a biopsy.
Dr. White?
Well, I'm glad both of the guys mentioned gastroenterology. The way I look at this is actually more kind of my vision of where I see pulmonary going. I think we're in an amazing time for pulmonary. We're actually finally doing some stuff. We've done historically, pulmonaries was kind of like the closet in the end of the hall that people were doing bronchoscopies in for pneumonias, maybe a cancer. We're in the age of robotics, where we're going after lesions that are less than 1 centimeter, which is phenomenal and amazing if you think about it. We're going to the age of therapeutics, just starting that. Going back to the GI doctors, they've done an incredible job marketing themselves. It used to be 50 years old, you blow out your candles, you got yourself a colonoscopy. Now it's moved up to 45. We're starting to do low-dose screening CTs. Those are going to be start finding more and more nodules and polyps or more nodules. My thoughts in the next 5 to 10 years, pulmonologists won't be treating lung cancer anymore. We're going to be treating nodular lung disease. We're going to have tools that will say high-risk lesion. We're doing some biopsy, real-time pathology reads in the room. Then we can go ahead and treat it with whatever therapeutic was going to be out there. We're getting really close to that. CyPath is kind of going to be, in my mind, will be kind of the starting line to get this whole process started, going from where we're treating lung cancers and start paying attention to more nodular lung disease.
Yeah. So one of the questions that I have not answered asked about, and we're reading as clinicians and healthcare providers, we're reading about potential screening tests for lung cancer, blood tests for lung cancer, you name it. Why sputum? Why not blood or some other mode of or direct biopsy? So the great thing about the CyPath lung test is that it's a real-time cancer test. It is looking at the microenvironment of the lung at that time that the sputum is produced. And so when we say that something is unlikely or likely in our binary result, we are talking about real-time changes that are occurring in the lung. So you can use this in patients that have had previous cancers anywhere in the body, previous lung cancer. Unlike blood tests, which have echoes of the cancer floating around as proteins in the blood, and usually these tests cannot be used whenever there's been a cancer within 5 years, including lung cancer. The real-time exam of the sputum, I think, is a huge benefit that favors sputum analysis over the blood, and obviously not compared to going in and biopsying, but as all of our three panelists have mentioned, the risk in a bad lunger of a percutaneous needle biopsy or even a robotic biopsy is tremendous. And we haven't really talked about the finances yet of these high-end robotic procedures, but it is a very expensive test, and we're in an era of financial crisis and trying to figure out the best use of our money. And so having a cost-effective test like CyPath as compared to going after a low probability, as Dr. White just said, low probability nodule with a very expensive test, just I don't think makes sense to me.
This is actually a great conversation because we're not just talking about lung screening, we're not just talking about biopsies, but we're talking about risk stratification. So where do you start? What size of nodule do you take? For CyPath, I found it reliable to be from 6 millimeters or greater, right? For those patients that have already had a previous history of lung cancer, other risk stratification modalities may not be useful because they've already had previous history of other cancers, solid organ tumors. In the future is very, very, very wide. It's very bright. You can develop it in whichever way you need to, but a lot of this to piggyback on what Dr. Nicholson said. When I was in IP training, we were the goers. We were walking around with a scalpel, a figurative scalpel in our pocket, right? We're trying to go in and do the biopsies and do the biopsies and do the biopsies. This tells us when to not, which is great, because when you can tell a patient, like Dr. White said, your chance of you having a negative test from a biopsy is very high based on this other test that we have done, based on the sputum that you have given us, not some number based on age or your height and your weight and what the nodule looks like. It's a much more reliable tool, in my opinion, that when you're having that conversation with people. So we use it. I mean, I ordered it a couple of times just today on patients that have 6 and 6.5, 7 millimeter nodules, and they have history of other cancers. It's not really looking like a full nodule, like a ground glass nodule, and I'm expecting it to help me make a decision whether I go after that and perform a biopsy or not. Can we do the biopsy? Sure. Should we? It answers that, should we?
Should we? Absolutely. I'd like to thank the audience for joining us and the excellent questions. I'd like to thank our panelists who really have given insight. I will mention that Dr. Nicholson has done a wonderful View Medi talk on the CyPath test, which if any of you if you can follow the View Medi, it is very informative and very complete. So thank you, panelists, and thank you, audience, for being involved tonight.
To learn more about CyPath Lung, read our peer-reviewed studies and journal articles, or view the patient case studies mentioned in this podcast and many others, please visit www.cypathlung.com. If you're interested in ordering CyPath Lung for your patients, you can email us at dc@bioaffinitytech.com. That's dc@bioaffinitytech.com. Thank you for your interest in early lung cancer detection.